Hey everybody, welcome to today's NCLEX-RN review session. Today we'll tackle another unfolding case study and apply the clinical judgment measurement model. I want you to focus on how to interpret cues, choose safe interventions, and evaluate whether those actions are working. Stay with us until the end of this session. Let's begin.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
Here's our first section of our case scenario. It's about a patient who is a 40-year-old South Asian female presenting to an outpatient endocrine clinic. Her primary care provider referred her for suspected hypothyroidism after an elevated thyroid stimulating hormone level. Let's look into the clinic visit data. She was admitted around 9 o'clock on day 1. Actually, this is the visit at the clinic, and the reason for the visit is to evaluate for irregular periods, fatigue, suspected hypothyroidism, with the following vital signs: temperature 97.8 degrees Fahrenheit, heart rate of 58, respiration 16, blood pressure of 128/82, and oxygen saturation of 98%. She appears fatigued with dry skin, thinning hair, and the thyroid gland is diffusely enlarged, non-tender, and the breast has that milky discharge expressible bilaterally, no masses. And for the neuro, she has delayed deep tendon reflexes, no visual field deficits. Moving forward to the next section here, we have the history and physical. Chief complaints are the following: irregular menstrual periods every 2 to 3 months. There's fatigue and 15-pound weight gain. Her past medical history included polycystic ovary syndrome, diagnosed age 30, and that's managed with diet and exercise. She has seasonal allergies managed with cetirizine as needed. No surgical history and no known drug allergies. She's non-smoker, no alcohol use, vegetarian diet per Hindu beliefs. She lives with husband and mother-in-law visits frequently, no history of recent travel. She's fatigued, has weight gain, cold intolerance, and has oligomenorrhea, galactorrhea, and infertility for 2 years. And she has constipation, occasional headaches, no visual changes, and with dry skin and brittle hair. Let's go into the patient's vital signs for day 1 upon the clinic visit. A temperature of 97.8, 58 heart rate, respirations of 16, blood pressure 128/82, saturation of 98%. On day 2, upon her visit to the emergency department, temperature is 97.2, 52 heart rate, and 14 respiration, 130/84 for the blood pressure, and 97% on her saturation room air. So we have to look into the progress notes as well. On day 1, patient seen in endocrine clinic reports irregular periods, fatigue, weight gain, cold intolerance, and occasional galactorrhea. Physical exam reveals goiter, dry skin, delayed reflexes. Laboratories ordered thyroid stimulating hormone, free thyroxine, prolactin, lipid panel, brain magnetic resonance imaging scheduled, patient educated on hypothyroidism, husband and mother-in-law present, request vegetarian dietary counseling. Day 2, patient presents to the emergency department with worsening fatigue, confusion, and leg swelling. We have here our healthcare provider orders on day 1 when she visited the clinic. We have laboratories for thyroid stimulating hormone check, free thyroxine, prolactin, lipid panel, brain magnetic resonance imaging to evaluate pituitary, and consult dietitian for vegetarian nutrition counseling. Follow up in 1 week or sooner if symptoms worsen. We have here the results for the laboratory test. Her TSH level is at 45 milliunits per liter, free thyroxine of 0.3 nanograms per deciliter, prolactin of 80 nanograms per ml, total cholesterol of 240 milligrams per deciliter, and low density lipoprotein of 160 milligrams per deciliter, and sodium 130 milliequivalents per liter, and potassium of 4.8 milliequivalents per liter. And the brain MRI showed 5 millimeter pituitary microadenoma. Since this is a bow tie question, when you're going to encounter this type of item, I want you to carefully scan the overall clinical picture. You got to look into the laboratory results, the vital signs, how the patient is doing, as you were seeing into the history and physical exam. Now, when you're going to approach the potential condition, I want you to think for yourself, what condition could explain everything I'm seeing? And then after that, you need to prioritize. Ask yourself what you need to do first to help this patient stabilize. And when it comes to monitoring, you got to ask, what 2 things will tell me if my treatment is working right now? So we have the following options for the boxes for the potential condition. Here are the choices. There's syndrome of inappropriate antidiuretic hormone secretion, non-convulsive status epilepticus, secondary adrenal insufficiency, hypothyroid crisis, and pituitary adenoma-induced hypopituitarism. The answer to this box is hypothyroid crisis. This is basically myxedema, the patient is showing all the classic signs of myxedema, which is a life-threatening complication of severe hypothyroidism. And when you go back into the assessment results, the patient has bradycardia running in the low 50s. She has low body temperature. There's mental confusion, puffiness in her eyes. There are swollen legs. There's also extreme fatigability, right? And when you look into the lab results, the TSH is really high at 45 milliunits per liter. Her free thyroxine is very low, which is 0.3 nanograms per deciliter. And both of these labs confirm primary hypothyroidism. And when you go back a little bit into the tables, she has not had her period. And she has high prolactin level, which is 80 nanograms per ml, which also is a hint of other hormonal imbalances. But for now, the emergency is that the thyroid levels are dangerously low. All right. Now, the other conditions don't really fit here. If you selected SIADH or syndrome of inappropriate antidiuretic hormone, well, this could probably explain a little bit about the sodium and confusion, but it doesn't match with the low temperature, the bradycardia, and the abnormal thyroid labs. That's why you're going to eliminate this one. Now, if you selected non-convulsive status epilepticus, sure, it probably can cause some confusion, but nothing suggests she had seizures. The client symptoms that we are seeing are about metabolic issues rather than neurologic. Now, if you selected secondary adrenal insufficiency, maybe, but look into the potassium. Potassium level right now is 4.8. And the blood pressure, when you go back into the vital stable, it's not crashing. It's actually within the normal range. And the real issue is the sky high thyroid stimulating hormone. This points to a thyroid crisis. Now, if you selected pituitary adenoma-induced hypopituitarism, this is the microadenoma. She has that one. But the pituitary right now is actually trying to help. And that high TSH tells us the pituitary is still working. So the problem is in the thyroid itself. It's not the brain. Now let's move on into the two nursing actions. We have the options: administer 3% hypertonic saline, consult neurosurgery urgently, start lorazepam IV, administered IV levothyroxine, initiate fluid restriction, administer hydrocortisone intravenously. The two actions should be administer intravenous levothyroxine. So let's get this one first. Now, this intervention will get the thyroid hormone back into her system quickly. And the IV route is preferred over oral form because our patient is actually disoriented. Of course, there are signs of altered mental status. And another reason why PO will not work here, because it might not be absorbed well, especially in this sick patient. And when you're going to administer IV, it's going to work faster, and we need to act fast, especially that the patient is actually in the myxedema coma stage. Now, the other intervention you should select is the hydrocortisone IV. Why? Because when a patient has this crisis, and when you give them an IV thyroid hormone, it can speed up the metabolism and it can uncover hidden adrenal problems. Now, if the adrenal glands cannot keep up, the patient could go into adrenal crisis, which can be fatal. So we give steroids just in case until we know for sure her adrenals are okay. Now, if you selected fluid restriction here, initiate fluid restriction, why do you think this is incorrect? Well, this is intended when a patient has SIADH, not myxedema coma. And so this patient might actually need IV fluids this time to help her blood pressure if it's going to tank. And the IV lorazepam is something that we're going to use whenever there are seizures, but she's not seizing. There's no signs pointing to that right now. If you selected consult neurosurgery urgently, well, this can be indicated if there is an emergency going on. And her brain tumor, which is microadenoma, isn't causing pressure or it's not causing vision problems right now. So it's not needed at the moment. If you selected administer 3% hypertonic saline, this is indicated if there is severe hyponatremia, in such cases that the patient may be really prone to developing seizures. Now, at the moment, you go back into the sodium level, it's 130. It's mildly low. And this is something that is likely going to improve once we fix the thyroid issue. So 3% hypertonic saline at the moment is somewhat too aggressive for this low sodium level. Now, let's move into the parameters to monitor. Make sure that you selected those correct ones. We have options: electroencephalogram activity, we have serum cortisol levels, heart rate and core temperature, visual field and acuity, serum sodium levels, and mental status and level of consciousness. The answers are mental status and level of consciousness. So let's focus on this one first. This is a key sign that the patient is improving. If she becomes more alert and less confused, the thyroid hormone is working. Now, the other answer is heart rate and core temperature, because these are actually low in myxedema coma. And if the treatment has kicked in effectively, you're going to see heart rate going up and the body temperature will return to its normal range. So the other options here, such as sodium levels, this is incorrect because this is something that can eventually improve on their own once the thyroid levels are better or treated. This is important, but it's not your main indicator of the success of the interventions. Now, if you selected eye examination or visual fields and acuity, these are useful for big pituitary tumors that are pressing into the optic nerve, but it's not needed right now. If you selected serum cortisol levels, this is going to be checked later, but you don't wait for results to start steroids, so delaying could put her at risk. And if you selected EEG activity, this is to check for the patient's brainwave. This is something helpful if you think she's having seizure, but not in this case scenario. So I hope that you have selected those correct ones. And before you go ahead and look into the next item, I want you to reflect on to the rationales for this test item. Let's move on to our next item. It says here on day 1, the nurse reviews the patient's symptoms and lab results to identify hypothyroidism. The findings are in the table below. We have categories and the finding. So there's that fatigue, weight gain, menstrual irregularity, galactorrhea, cold intolerance, constipation, thyroid stimulating hormone, free thyroxine, prolactin, and physical exam. So in this test question, you are tasked to pick out the strongest signs of specific disease process, and you're going to look for those findings that are not just common symptoms, but the defining features. Those are measurable or observable and are less likely to be caused by something else. So here, I don't want you to get distracted by the other symptoms that are vague, that are subjective, or could be linked to other chronic conditions. So I want you to focus on what screams, this is a primary issue right now. So this is a highlight hotspot type of test item. So make sure that you're selecting those items that would really strongly indicate hypothyroidism requiring immediate management. So one of those is the TSH level of 45 milliunits per liter. This is the clearest laboratory marker of primary hypothyroidism, and this is a very high level that tells you that the pituitary is working too hard to stimulate the thyroid gland, but the gland, I'm referring to the thyroid gland, is not responding. So this is basically hormone failure by the thyroid gland. And this level doesn't just confirm the diagnosis, it also signals urgent need for hormone replacement to avoid further metabolic slowdown or other complications in myxedema coma. The other item that you should highlight is the free thyroxine of 0.3 nanograms per deciliter. This is the active thyroid hormone that's circulating in the blood, and a low T4 alongside with a very high TSH completes the classic pattern of primary hypothyroidism. Now, when T4 this low, the symptoms will actually worsen, and if you're not going to treat this right away, the body can decompensate, especially in this patient. Now, the other findings are in the physical exam. There's diffusely enlarged thyroid, dry skin, delayed deep tendon reflexes. These are clinically classic signs for hypothyroidism. There's that goiter. It suggests the gland has been overstimulated over time. And the dry skin results from very slow metabolism. It's actually impairing skin turnover. And the delayed deep tendon reflexes is very slow. And the relaxation phase is much more extended. This is a reliable neurological finding in hypothyroidism. It's not subtle. This is something that is obviously assessed. And so all these manifestations help you directly assess that the patient really is having that hypothyroidism, that you need to promptly treat this patient. And so the rest of the options or rows that we have here, such as fatigue, is not highlighted here because this is common. This is expected in hypothyroidism. This is also seen in other problems such as anemia, depression, sleep disorders, and other issues. It is non-specific, and this can't be used alone to make a diagnosis. Now, the weight gain, 15 pounds over a year, no dietary changes, well, this is not diagnostic. It could be lifestyle related, or maybe insulin resistance, or maybe PCOS, or medication side effects. So it doesn't really tell us much as the lab values or the physical exam that we are seeing. So these are just supportive. This is a supportive manifestation. Now, if you selected menstrual irregularity, it said here, periods every 2 to 3 months for 1 year. Now, this is linked to hypothyroidism as well, and also common in PCOS and other endocrine disorders. This one adds to the hypothyroidism, but it's not strong enough on its own to point directly to hypothyroidism. Now, the galactorrhea, which is that milky nipple discharge, this indicates that there is hyperprolactinemia, which is a secondary effect of hypothyroidism. And it could suggest a pituitary issue like a microadenoma. This is also relevant, but it's not the primary cue for the thyroid dysfunction that we are seeing in this case. Now, if you selected cold intolerance, feels cold frequently, wears extra layers, this is a classic symptom. Yes, it is, but it's entirely subjective. People can feel cold for many reasons, including anemia or just low body fat, and this is not a reliable or measurable finding in clinical decision making, and that is why we're not prioritizing this one. If you selected constipation, it said bowel movements every 3 to 4 days, hard stools. This reflects slowed bowel motility, which is typical in hypothyroidism, but then again, this is a non-specific symptom. This could be attributed to dietary changes, could be lack of hydration, or maybe due to other gastrointestinal issues or medication issue. And this one doesn't really require immediate management. If you selected prolactin of 80 nanograms per ml, this value is significantly elevated and is secondary to hypothyroidism. Or it could point toward pituitary adenoma. We know that this is something that is also important, but prolactin here isn't a primary marker for diagnosing and treating hypothyroidism. It's something that can complicate the case, but it doesn't define it. Again, go back into the question. It said we are only highlighting those findings that strongly indicate hypothyroidism requiring immediate management. Again, look into those cues that I just mentioned, those that are measurable. All right, let's move on to our next item.
Before moving ahead, here's something you need to hear if you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month, then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's jump into the topic.
It says, in the intensive care unit, the nurse monitors the patient for complications of myxedema, hyperprolactinemia, and underlying conditions. So here's our matrix. Now, before you're going to answer this question, this is a question that's asking you which complications require close monitoring and which ones can be safely placed lower in the priority queue. So I want you to think, what could deteriorate quickly if you're not monitoring this? and which issues have the potential to cause harm today. And if a complication is a long-term, or maybe if it's going to involve a much more of long-term effects, or if there's no current evidence of it worsening, it might not be a high priority right now. So let's talk about the high priority items first. So these are the issues that going to demand immediate attention because they can lead to rapid deterioration or have serious consequences if we're going to miss dealing with that issue, even if the signs are subtle at first. Now, let's have the first item, mixed edema, progression. What do you think about this one? This is a high priority. This is a big red flag. Absolutely, we need to put this in the high priority, because when this patient is in this status, their whole body is basically shutting down from extreme hypothyroidism. And so think of really slowed breathing. There's very low blood pressure. Their heart rate can really tank, maybe low as low as 40s or maybe 30s, and they can slip into unconsciousness or even coma. And these changes may seem subtle at first, like the patient is just tired or maybe disoriented or confused, but they can quickly snowball into respiratory failure or even death. So we just don't check vitals occasionally. We're actually constantly monitoring their mental status, their temperature, their heart rhythm, and their respiratory function. Because even small changes might be the first warning signs that the patient is going downhill really fast, and you got to act on this very quickly. Now, the other high priority is pituitary adenoma mass effect. It's small, but it sits in a really sensitive spot, so we just cannot ignore this one. Even though this microadenoma sounds minor, it's not where it sits that makes it dangerous. The reason that we're concerned about this one, because it's about the location. The pituitary gland is tucked right under the optic nerves. And if the tumor grows even just a little, it can press on to the optic nerve and it can mess the patient's vision. And the patient might not complain of vision changes until damage is already has happened. And so we're going to keep a close eye out for any signs like blurry vision, if they're going to have headaches or any changes in their alertness. So definitely we're going to do frequent neuro checks here, and we have to follow up for the imaging, and that's part of our ongoing care, not because something is wrong now, but because the risk is too high to wait until it is. Now, another thing that you're going to consider as high priority is dyslipidemia related cardiovascular event, because we have an issue about cholesterol this time, which has long-term effects. And when a patient has a very sky-high lipids, and if they have hypothyroidism, their heart is under double pressure. And take note that the patient is already bradycardic. Their blood vessels become stiff, and this increases their risk of clotting. There is also sluggish circulation in this patient. And so combine that with the abnormal cholesterol levels, the risk of a heart attack or arrhythmias can happen anytime. It's just not years from now. And that's why we're going to monitor this patient for any chest pain, arrhythmia, and other signs of ischemia right away. So we're not just thinking about preventing future problems. We are going to watch this patient for something that could happen during this current admission. And so the rest of the complications here are going to be placed low priority. So we are considering them as low priority because they are still important from a big picture perspective, but they do not require urgent intervention in this patient, especially in the ICU. These are things that can be safely addressed later once the other acute issues are already addressed or under control. Now, why is anaphylaxis from allergies considered a low priority this time? That's quite tricky, right? If you were going to read anaphylaxis from allergies, Well, that sounds scary, but it's not even on the table right now. We know that anaphylactic reactions or allergic reactions are emergencies, but in this particular case, this patient doesn't show any signs of being at risk. Nothing about anaphylaxis is even described in the clinical case scenario. There's no recent exposure to allergens. There's no previous reactions noted. And the only thing in the picture is an over-the-counter antihistamine, which is actually meant to prevent allergic symptoms. It's not going to cause them. So although we always want to be aware of allergy history, this is not something we need to watch closely right now. We can keep it on the chart, but our focus needs to be more on the other pressing issues. Now, what about the polycystic ovary syndrome related infertility? Why do you think? Let me check that box right there. All right. Why is it that we're going to put low priority for the PCOS related infertility? Well, this is something that can also matter, but not during this critical care admission, because the effect of this condition are not really going to be urgent right now. And it's not going to affect the patient's survival during this acute crisis. We know that infertility, irregular periods, or hormonal imbalance are valid. We know that these should be addressed, but after the patient is medically stable. Okay, so this is something that you need to explore, or the patient needs to be treated with in probably an outpatient follow-up when the focus shifts to more of a long-term health and life planning. So right now we need to save our energy for what's immediately life-threatening, and that's why this is low priority. Now, when you're going to deal this patient, especially in critical care, it's not enough just to know what the complications are. We have to prioritize based on what can spiral out of control quickly. And the right call for this case could be the difference between stabilizing the patient and missing those subtle but dangerous events. So always ask yourself, which of these problems could become a crisis in the next few hours? So that what earns spot on your high priority watch list. All right, let's move on into our next test item. This is a multiple response grouping to test your clinical judgment in generating those solutions. So it says here, the nurse develops a care plan in the intensive care unit for myxedema, hyperprolactinemia, and cultural needs. So here, you're going to match the interventions to the different categories. There's that acute illness, there's that chronic hormonal imbalance, and cultural support. So for each intervention, you got to ask yourself here, what's considered a first-line action for this condition or situation? So I don't want you to jump right ahead into those specialized or invasive steps. And when it comes to cultural care, think about what would feel personalized and respectful based on the patient's background, not just in general. So we have the categories here and the following intervention. So for the myxedema coma management, the interventions here should be to give the intravenous levothyroxine, because when someone is in that kind of state, their body is shutting down because of how little thyroid hormone they have. And this is our go-to treatment because it works fast, it gets absorbed properly, unlike oral medications in critically ill patients. And the priority is to bring up the thyroid hormone levels very quickly and safely to pull them out of that dangerous state. Now, the other answer is to give hydrocortisone intravenously. All right. So before starting the thyroid hormone therapy, you need to think about the adrenal glands, because hypothyroid patients might also have hidden adrenal insufficiency. And if you suddenly replace this patient with a thyroid hormone, it can unmask it. It will potentially cause a crash in their blood pressure or their blood sugar. They can go into hypotensive crisis and hypoglycemia. And so when you give the hydrocortisone IV, it covers that risk and to know that their adrenal function is okay. Now, why is initiating oral propranolol incorrect this time? Remember that this is a beta blocker. It can cause the heart rate to go down. It can cause hypotension. This is a drug that we administer for those patients that have hyperthyroidism, where everything is really fast. There's tachycardia, there's hypertension, they have anxiety. But in this case of myxedema, all the processes are very slow. There's hypotension, there's going to be bradycardia, low body temperature, respirations are low. And so if you're going to give propranolol, this would make things worse. And so we're going to eliminate that one. Now, if you selected oral potassium iodide, this is indicated for hyperthyroidism cases because it's going to slow down the thyroid hormone release. The problem that we have is the lack of thyroid hormone, not an excess. So this is exactly the opposite. And if you're going to give this medication in this patient, it will further suppress the thyroid function even more. So basically, eliminate this. Now, let's move into hyperprolactinemia management. The correct answers here is, one of those is to initiate cabergoline as prescribed. This is our first line of attack for high prolactin levels due to the pituitary tumors. This is something that will work as a dopamine, which naturally lowers the prolactin. And this is very effective and often gets the prolactin levels back to normal, which will help with the symptoms like irregular periods or for infertility. Now, the other interventions that you should select here is to monitor prolactin levels weekly, because once the treatment starts, we have to keep an eye on this level to see how well the medication is working. And the weekly checking will help us tweak the dosage. Of course, it's the physician's responsibility. And also, it makes sure that things are heading into the right direction early on. Now, the other options are incorrect, such as the administration of dopamine IV. Why? Even though the dopamine can play a role in lowering the prolactin, but we don't use IV dopamine for this one. It's something that is indicated for short-term cardiac support, not hormone control. Now, I'm talking about infusion dopamine. That's why it's not applicable. And this medication does not target the pituitary tumor the way the cabergoline does. Now, what about consult neurosurgery for pituitary adenoma resection? Now, pay attention to the phrasing here. It said, consult neurosurgery for pituitary adenoma resection. Now, this is not to be checked on because surgery usually is the last resort for big tumors that can cause pressure or if the medications don't work. Now, if the tumors are small and if we haven't even tried cabergoline yet, there is no reason to rush into something that is more invasive. That's why we are not checking this box. For the last category, it said cultural support. Now, what do you think would be the interventions here? This include husband and mother-in-law in care discussions, because in many cultures, the family plays a huge role in the decision making and healing. And if the patient finds comfort in having her husband and mother-in-law involved, then we should include them. It also shows respect for her values and supports her emotional state as well. Now, what else? We are going to contact the patient's Hindu priest for spiritual support, because this works also matches the patient's beliefs, and with her religion, connecting her with her own spiritual leader like her priest can be really comforting. It's much more meaningful than offering generic services. Now, the other two are incorrect. If you selected generic spiritual counseling, this might seem helpful on the surface, but if the patient has specific religious beliefs, a general counselor might not offer the support she really needs, so eliminate that one. Now, what about offer aromatherapy for relaxation? Sure, it might help some people relax, but unless we know this patient finds it meaningful, it's not really addressing her cultural or spiritual needs. And in this case, other options are more relevant. So for this test item, the whole scenario shows how important it is to think critically and to tailor your nursing actions, whether it's a life-threatening hormone imbalance or simply respecting a patient's beliefs. So here, we can not just throw standard treatments or one-size-fits-all type of solutions in a complex case. And remember that the goal is always to act with precision, make sure that there's empathy, medically and also culturally. All right, let's move on to our next test item. It says, in the intensive care unit on day 2, the patient exhibits persistent confusion, a heart rate of 50 beats per minute, a temperature of 97 degrees Fahrenheit, periorbital edema, and bilateral leg swelling. The patient's husband and mother-in-law expresses concern about her confusion and requests alignment with the Hindu spiritual practices during treatment. The nurse is assessing potential causes of persistent confusion to guide immediate management while considering the family's cultural needs. I want you to carefully scan through the laboratory test results here. We have a new set of lab values for the TSH. It's at 48 milliunits per liter, and free thyroxine 0.2 nanograms per deciliter, prolactin 85 nanograms per ml, and sodium of 128, potassium 4.9, glucose 65. Now let's get into the instruction here. For each potential cause of the patient's persistent confusion, indicate whether it is high priority, which means requiring immediate action within the next hour, moderate priority, requiring action within the next 4 to 6 hours, or low priority, requiring monitoring but not immediate action. Select one priority level per cause. So we have the potential causes: myxedema, progression, symptomatic hyponatremia from hypothyroidism, hypoglycemia secondary to metabolic dysfunction, and pituitary microadenoma mass effect, and lastly, delirium from ICU environment and cultural distress. Again, I want you to select carefully if it's high priority, moderate, or low priority. Now, for the first potential cause, what do you think about this one? This is strictly high priority because this is what's causing her confusion, the hypothermia, the bradycardia, and swelling, all pointing to myxedema, This is life-threatening if not aggressively treated. And this is a true endocrine emergency. And even though she's already started on the IV levothyroxine, she might not be fully stabilized yet. And confusion is a classic sign of central nervous system involvement, and it might get worse before it gets better. And that's why we are placing this as a high priority. Now, the clinical picture here actually fits the diagnosis like a glove. So this is the main driver of her confusion, and the one point that can worsen rapidly if not managed appropriately. And we cannot afford to delay this. It demands immediate attention right now. Now, why do we avoid putting this as a moderate priority? Well, because if we are not treating, this can worsen the coma. It can even cause death. And this is not a monitor and wait kind of situation. This is the root of the problem. Now, moving into the next potential cause, symptomatic hyponatremia from hypothyroidism. Now, I want you to go back into the sodium level of 128. What do you think about this one? Well, the answer is moderate priority. That sodium level is low, but not critically so. And the sodium level at this time can cause confusion, but we can generally get more concerned if it's going to be much lower than 125 or below. This is the time when you are going to see seizures and coma related to hyponatremia. Now, in hypothyroidism, this type of hyponatremia is often delusional. There's too much water retention, not necessarily sodium loss, and it usually corrects itself as the thyroid issue gets treated. Now, why is this a moderate priority? Because it's contributing to her confusion. It's not the main threat at the moment, but still we need to monitor it and make sure this value does not drop further. Now, when we are going to put this as a high priority, only if the sodium level is lower than 125 milliequivalents per liter, especially if there's going to be worsening neurosymptoms, if there's stupor or if there's seizures, then you're going to act fast, probably with the use of that hypertonic saline solution. Now, what about hypoglycemia secondary to metabolic dysfunction? So don't forget, scan back into the lab data. We have a 65 milligrams per deciliter here. So what do you think is the answer? This is moderate priority. This is low, but not dangerously low. We usually reserve the term critical whenever the glucose level is below 50 milligrams per deciliter, where we're going to expect seizures or even loss of consciousness or other worse manifestations. Now, in critical illness, any metabolic instability can cause these dips in the glucose, but her level is just borderline right now. Now, why is this moderate again? Well, this could add to her confusion, so we should keep checking her glucose levels regularly, and possibly she's going to require a little bit of glucose, maybe orally, if she can swallow the solution safely. But right now, it's not the driving cause of her mental status change. Again, we are only going to consider this a high priority if her glucose went below 50 milligrams per deciliter, and if she developed more neurological symptoms, then that becomes an emergency. And this is going to call for an intravenous injection of D50. All right. Now, moving into the pituitary microadenoma mass effect. What do you think about this one? Also ranked, that is also important, but at the moment it is a low priority. The size is 5 millimeter. It's pituitary microadenoma. This is also common and usually doesn't cause any symptoms unless they are larger, maybe over 10 millimeter in size. But at the moment, she has no visual field deficits, which is one of the first signs that you would see if the tumor is pressing into the optic nerve. Now, with the patient's confusion, this is way more likely caused by the severe hypothyroidism than the tiny adenoma. Now, why do we put this as a low priority? It's because we need to monitor her pituitary function over time, but there's no need to take urgent action unless there are new neurosymptoms that will show up. However, this can become moderate or high if she suddenly develops visual problems, or if there's going to be severe headaches or any signs of increased intracranial pressure, then this would be pumped up in its priority. At the moment, it's low. Now, what about delirium from ICU environment and cultural distress? Well, ICU delirium is definitely a real concern because of fluorescent lighting. There is also sleep deprivation and unfamiliar sounds, such as the beeping of the monitors, IV pumps. And so this can really mess up their mental capacity, or even not mental capacity, but their neurofunction, especially that they're already stressed emotionally. And also the cultural differences, it can really overwhelm the patient. And in this case, though, the patient's severe hormonal imbalances are the bigger issue. The delirium might be a piece of the puzzle, but it's not the priority right now. Why do we put this as a low priority? It's because we should still respect the cultural and spiritual preferences of the patient and the family, which is also part of the holistic care. But from a medical standpoint, this isn't what's primarily causing her confusion. Now, we can put this as a moderate or high priority when she becomes agitated, or if she tries to pull out IV lines, then that's a totally different story. Or if the distress will worsen all the more, which can cause worsening of her condition, then that's the time we're going to escalate the need or the priority for this potential costs. Alrighty, let's move on into our next item.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's continue with the topic.
Last but not the least, it says, after 48 hours in the intensive care unit, the patient's mental status improves, heart rate increases to 68 beats per minute, temperature normalizes to 98.6 degrees Fahrenheit, and edema decreases. Laboratory shows thyroid stimulating hormone 30 milliunits per liter, free thyroxine of 0.6 nanograms per deciliter, and prolactin 50 nanograms per ml. And we have here our instruction to select the outcome that best indicates successful management for each condition. And these three are the following: hypothyroid crisis, hyperprolactinemia, primary hypothyroidism. Now, this question is asking, how do you know the treatment is working? So here's how to think it through step by step. So you're going to start with the condition that you're dealing with, and each of the condition or situation has certain signs that tell us whether the treatment is helping. And so these could show up in how the patient looks and how they're going to feel, maybe through the lab results or the relief of the manifestations, right? After that, you're going to ask yourself, what would I expect to improve first? Because not everything gets better right away, and some signs show up early within the first 24 to 48 hours, while others take days to weeks. And for this kind of test question, you need to focus on the short-term outcomes and the changes that would realistically happen in the first couple of days if the treatment is doing its job. So I want you to think here as a nurse at the bedside and make sure that you choose the outcome that would clearly reflect clinical improvement soon, not something that's more of a long-term goal. So what do you think would be the answer for the outcome here? Of course, we have the following options. So for the hypothyroid crisis, what do you think? So here are the options: prolactin level of 38 nanograms per ml, improved thyroid function tests, resolution of galacturia, normalized serum sodium levels, reduced total cholesterol, resolution of periorbital edema, improved deep tendon reflexes, stabilization of blood pressure, absence of pituitary adenoma mass effect, and improved mental status and vital signs. All right, I hope that you have decided your answers for the three conditions. So for the hypothyroid crisis, the outcome should be improved mental status, and vital signs. These are the best indicators, especially when a patient is in a hypothyroid crisis, because we are dealing with a life-threatening state of extreme hypothyroidism. And the early signs that our treatment is working won't necessarily come from the lab test. They'll show up in how the patient acts and how they're going to feel. So in this scenario, if the patient starts waking up, if they start talking, they become less confused, and if their heart rate, their temperature begin to normalize, those are the great signs that the IV levothyroxine and that the hydrocortisone IV is working. All right. So this tells us the metabolism is actually revving up, which is exactly what we want. And so the rest of the answers here, like reduced prolactin level, this is not really going to match for this condition. Now, if you selected improved thyroid function test, also a mismatch. This is something that's important, but they don't change quickly. We don't rely on the laboratory to tell us whether the patient is stabilizing in the first 1 to 2 days. We're actually talking about the now. The laboratory results can actually have some significant changes after, let's say, close to a week. All right, so this is not something that you're going to expect to show up in the lab right now. If you selected resolution of galacturia, this is actually linked to the high prolactin levels. It's not directly to the treatment of thyroid coma. And the normalized serum sodium levels, we know that this is something that can improve if the thyroid levels go up. This is a slow and secondary improvement. It's not the main focus in this case. Now, if you selected reduced total cholesterol, this is a long-term benefit if we are treating the patient's hypothyroidism. This is not something that we are supposed to expect within the first 48 hours. Now, resolution of periorbital edema, which is the puffiness around the eyes, this is going to go away over time, not really possible within the first 48 hours. Now, if you selected improvement of deep tendon reflexes, the reflexes can slow down with hypothyroidism, but this is something that can be restored within a matter of weeks to normalize, not the priority right now. If you selected stabilization of blood pressure, this is helpful, but the heart rate, the temperature, and the mental status will it will give us better picture about the recovery of this patient. Now, if you selected absence of pituitary adenoma mass effect, that's something that we'd worry with pituitary tumors, not about the primary hypothyroidism. Now, let's move on to hyperprolactinemia. What do you think would be the best outcome here? That should be prolactin level of 38 nanograms per ml, because in this condition, especially that they had a pituitary microadenoma, the goal is to get those prolactin levels to drop. Now, if the prolactin goes from 80 nanograms per ml and down to 35, that's a huge improvement after they have received the treatment such as the cabergoline. This is a huge sign that the medication is working, even if it's not fully normal yet, and making sure that the medication is actually effective. So it's turning off the hormone production, and we're actually moving into the right direction right now. Let's move into the primary hypothyroidism. What do you think would best fit in this condition? The outcome for this is improved thyroid function tests. This is very straightforward. If your patient has primary hypothyroidism and you have started them on the levothyroxine IV, you want to see the TSH going down and the free T4 going up. Even if they are not fully normal yet, you're going to see that trend that tells you the treatment is actually doing what it's supposed to do. Now, if you selected improved mental status and vital signs. These are more relevant to the hypothyroid crisis. And take note that with the primary hypothyroidism, it tends to be more of a chronic issue, and it doesn't usually cause rapid changes in their alertness. So primary hypothyroidism, it doesn't really cover about the crisis right now. And so these two are totally different conditions. Now, why not select reduced prolactin levels, even though this can happen in hypothyroidism? Well, this can actually happen with thyroid correction, but it's not the goal right now. And if you selected resolution of the galacturia, this can improve, but it's a secondary effect. It's not the main thing that we are monitoring. And for primary hypothyroidism, normalized sodium levels is basically much more linked towards a crisis, but not really about primary hypothyroidism. And if you selected reduced total cholesterol, this is more of a long-term benefit, but not something that we'd expect to change within the 48 hours. And the resolution of periorbital edema, this can resolve slowly, but again, not a priority monitoring parameter. And if you selected improved deep tendon reflexes, we know that this can be sluggish, but they take a long time to recover as well. And stabilization of blood pressure, well, not really, because the blood pressure here can fluctuate. But then again, the lab values are more reliable for tracking the patient's improvement from their hypothyroid state. And if you selected absence of pituitary adenoma mass effect, this is not part of primary hypothyroidism. This is of a different problem entirely. So before we're going to wrap up, here's something to keep in mind. This case was not just about memorizing facts. It's about learning how to think like a nurse. And keep in mind that every decision point asks you to pause, make sure that you prioritize and act with attention and intention. And you want to also use the pathophysiology here. Make sure that you do not neglect the patient's assessment findings. Those are important cues. And also discriminate if there is urgency in that clinical situation. Now, since we are managing this hypothyroid crisis and also with the hyperprolactinemia, it simply means that we are actually managing a life-threatening condition and something that we can treat when the patient has already been stabilized. So this is basically testing your judgment to differentiate which one needs more urgent attention than something that will require attention maybe in the next 48 hours or so. And as you prepare for the NCLEX, remember, it's not just about choosing the right answer. It's about building sound clinical judgment that keeps our patients safe. So that's the close of our Q&A today. Remember, the goal isn't just getting the right answer. It is developing the clinical instincts to know why that answer matters. At this point, I want you to keep practicing how to analyze the cues, take timely action, and reflect on the outcomes, because those are the exact thinking skills that the NCLEX demands from you. So stay focused, trust your reasoning, and carry this mindset into every question and every shift.